Thanks to everybody. With the changes that are pending in mental health care coverage and the changes that are pending in Medicaid kind of driving it, at some point in the very near future, the Alleghany County Commissioners will have to decide if we are going to continue to use Via Health as our managed care organization, or if we are going to move to another organization, which would probably be Partners, would be the only other one that would make sense. Okay. So when the Medicaid transformation is complete in June of 2021, like that's going to happen, but we'll still go under the assumption that everything's going to happen on time. The role that our MCO plays will be different than the role it plays today. So the state has been trickling information out little by little, and there are still a lot of things we don't know yet about what's going to happen in 2021. I think we can all agree that in general, the state of mental health care in the great state of North Carolina is not where it should be. It has been underemphasized and underfunded for years. We're not going to change that today. If we decide to change from Via to Partners, we're not going to change the overall general underfunded and underemphasized state of mental health in North Carolina. So just kind of keep that in mind. After today's meeting, and there will be an yet undetermined number of additional meetings, the county commissioners will have to make this vitally important decision. So we've invited you all here today to assist with that decision. So the commissioners are seeking directly relevant information to make a better informed decision. So some of the questions we just threw out as a starting point here on the podium, what's going well in our mental health care providing right now, what needs to be improved, and which entity is best equipped to handle that role that the MCO will be fulfilling for 2021 and beyond. As human beings, we all suffer from the grass is always greener syndrome. The next job, the next meal, the next car is always going to be better than the one we have now, right? So we want to keep that in mind as well. Some of the other things we want to think about, involuntary commitment process, substance abuse diagnosis and treatment, Alleghany in Motion, how do they fit into the equation? Is that a training session for county commissioners and county managers on Medicaid transformation a couple of weeks ago? We were in Durham the day the building blew up. I was 3 doors down there. And that was almost every question that came up was around public transportation, non-emergency Medicaid transportation, how's that going to fit? And nobody had any answers. State didn't know, nobody knew, so we just, and that's a big part of our budget. We would not be able to offer public transportation if we did not have the non-emergency Medicaid medical transportation, so it's another thing we have to think about. This is a public meeting. We did advertise it since we have a majority of the county commissioners here. There will be no action taken today, and there's no official public comment period. We wanted this to be informal and kind of a roundtable type session. We are filming though. It's not live streaming, but we are filming it just so we can refer back to it later if we need to. At some point prior to making the formal decision, the commissioners will conduct at least one public comment period at a regular board meeting. But we want to try to keep things on point and finish in around 90 minutes today if we can. So kind of keep these 3 questions in mind, and let's kind of start with things that are going well. Drew has a cordless microphone that she will kind of pass around if somebody wants to start kind of what's going well. If you would, your first comment, if you would sort of introduce yourself and say, what role kind of you're playing in the mental health care universe, and then so kind of go around and get some feedback on what's working well right now. So.
Mental health. So I haven't been here very long. As far as I'm concerned, things are going well with what I'm doing with individual practice, but I do know Medicaid's often very challenging. Lots of hoops to jump through as a practitioner. I do just individual therapy, and there's always new things that you've got to do to meet this standard, dot this I, cross this T, so you can kind of stay in network and do all those things. So it's pretty tough for the practitioners just to kind of keep up with the demands. But, other than that, I feel like for me, things are going pretty well.
Medicaid specifically, one of the challenges we have is that population tends to be fairly transient. They don't always, they may move around a lot, that kind of thing, and they don't necessarily want to open a letter that's addressed from the county government or the state government. They don't always want to have more interaction with the local government than they have, and we're going to have to try to get them all to choose a new Medicaid plan, and that's going to be a great challenge. I'm glad that's not under my purview. So thanks for your comments there, Dallas.
I have some questions. Now, how do you receive your clients?
For
Are
me,
they
it's
referred by VIA, or are
Not-
you under contract with VIA?
I am under contract with VIA, yes.
Okay.
But mine are referred from local primary care physicians and then self-referrals.
If I want to use your services, I'm not on Medicaid or Medicare, can I call you and make an appointment? Do I have to call someone at VIA to make an appointment? What's exactly the process?
You would call my office, and then we would set you up to come in and do an intake.
Okay, and that information would go to VIA, I guess?
Yes, if the individual had Medicaid, yes, that would go to VIA eventually.
Okay. Thank you. Next. Again, if you're just here to listen, that's perfectly fine too, if you don't need to turn at the mic, so.
Okay, I'm Amanda Edwards. I'm a licensed clinical social worker. I am a care coordinator for Partners Behavioral Health. I also live in Alleghany County. I also provide outpatient services with Capstone Wellness Center here in Sparta. And I think what's going well right now, one thing I can say is we do have the health department providing services now, so I think that's a great beginning to getting more services in the county.
My name is Amy Johnson. I just got married Saturday, so that's still a little weird for me to say. Most of you knew me as Amy.
Congratulations.
Thank you, thank you. Most of you knew me as Amy Douglas or as Amy Douglas Green. When I heard about this, I asked if I could please come and speak. I'm no longer practicing as a social worker. I say I'm retired now because I like saying retired better than disabled. But I am now a Medicaid recipient with mental health diagnoses who has tried really hard to navigate a very broken system in Alleghany County, and I have run into some very specific problems that I wanted to bring light to as far as what it's like being the little guy trying to do this work now. And I'm educated, I have a master's degree, I worked for 15 years in the system, and I can't navigate Medicaid right now. But what I can tell you is there is very little available in this county, service-wise. There is very little available anywhere else. And at some point, I would like to get into some more specifics. I reached out to several people in the community who sent me stories of loved ones that have died, loved ones, teenagers that got pregnant, waiting on a waiting list for services here in this county. And so I want to be a voice for those people today at some point in time.
Yeah, I think her one point was important. It's not just here that there's a shortage of
No, there
providers.
is not a shortage here. It's everywhere.
I mean, Nick and Robbie will tell you involuntary commitments, we wait days,
Yes.
weeks sometimes, and we may take them all over creation to try to get them placed somewhere.
Exactly,
And it's
exactly. And I
so-
remember placing people, one of the hardest things I've ever had to do was to send a kid to Jacksonville, North Carolina that was 7 years old by themselves in a cop car because we couldn't get treatment anywhere else for this child. And that's not right. So that is not something we're going to be able to fix here. That is a much bigger problem. But I think there are definitely some things to consider as we're moving forward because this affects not only Medicaid recipients. Blue Cross Blue Shield now has some contract with VIA to do their mental health managed care. Medicare is no longer accepted at Daymark as a reimbursement source. That affects a tremendous number of people in this county.
Did you say Medicare or Medicaid?
Medicare.
Medicare.
They have
Okay.
stopped taking Medicare.
Sorry, Larry.
I go to the doctor and I get hit with will you come back to work? Will you come back to work? I go to the emergency room. God, we really wish you'd come back to work. There's nobody here. Everywhere I go, people are telling me. So I have some stories that I would like to get to a little bit later. But as far as what I think VIA does well, VIA has a really interesting model called the Comprehensive Care Center. And it's supposed to be a one-stop shop where you could get the full gamut of services that you could possibly need for anybody. It's supposed to be what's called a single portal, that there's no wrong door. You walk in and you're supposed to be able to get services. In Lenore, in Asheville, it works beautiful. It doesn't work so well in Sparta. It's hard to get staff hired up here, and it's hard then to be able to make the resources available that the county, the members, the community residents need, and then you can't travel because Medicaid won't pay to take you somewhere else because that service is supposedly available in the county, so therefore you can't use Medicaid transportation. So it's become a big, tied-up mess.
Really, any medical specialty is the same way.
Yeah, you have to fight to be able to get
We can't have a
medical-
urologist here 40 hours a week.
Yeah,
We
so,
can't
but
have
we
a
do-
cardiac surgeon here 40 hours a week.
But yet then you can't get Medicaid to pay for your transportation to go to Elkin. Yeah, so that is a problem. And I did not know that. I have learned that a lot of people were not aware that if the service is available in the county, you cannot use Medicaid funds for the transportation.
That's correct. The closest available facility, and that has a very narrow definition.
Yes, it does, very much so.
Learned a lot about Medicaid over the last few months. My previous job, I was an economic developer, and we would recruit a business, and you got to learn a little bit about, so 1 month I've got a foundry coming in that may want to locate here. The next month it's a furniture manufacturer. The next month it's a call center. I've got to learn a little bit about those businesses before they come in so I can speak somewhat intelligently to them, and that's where I am in the Medicaid process right now. I'm learning a lot about it the last few months.
And everything that you know right now will be different in 3 months.
Yeah.
That is the one thing I can guarantee, is it will change.
Thank you.
So,
Hi, I'm Jack Kahn, and I have a lot to say, but I'm here to listen, and I'll talk later.
Okay.
Because I think on this row, we're from VIA, so we're here to listen.
Okay.
Well, I'm George Edmonds. I'm with Youth Villages. Youth Villages is a nonprofit mental health provider in Alleghany County. We're a statewide provider, so we have contracts with every MCO across the state. We've been in Alleghany, serving Alleghany for about the past 7 years. We're what you would consider a niche provider in the system, so we're not a comprehensive provider. We do a few services for children and families, mostly in-home services, trying to keep kids with their family and not in out-of-home placements. In terms of, I think there's some real good achievements that VIA has made that affect Alleghany County. There's a big focus on the juvenile justice system, and when a kid comes in with a complaint with the juvenile justice system, we assess that child and make sure their mental health needs are being assessed, which is a big bonus that we have in the VIA area. VIA has made some real investments in in-home services and attracted some evidence-based practices like Intercept, which really works with families in the child welfare system who have experienced some abuse and neglect, which is shown to keep kids and families together versus out-of-home placements. And they've made big investments in one of our programs called YV Life Set, which is designed for kids who are aging out of the foster care system. And so if a kid becomes in custody of the state and is never successfully adopted or reunified with that family, they just age out. It has some of the worst outcomes that you can kind of imagine. They're more likely to be heavily in the service to make sure that those kids get services. That's part of a state grant that we got statewide, and so instead of just focusing, it's a 5-year grant, and instead of focusing on like Asheville, Greensboro, Charlotte, Durham, what's it going to take to get these services in Alleghany County within the first year? And so we were able to bring LifeSet in the first year of the grant versus, the 5th year of the grant. So we're really able to get, I think, good services as best as we can to rural areas. So.
Your organization deals with both VIA and partners. How about you personally? Have you dealt with both, or is it
Yes.
mostly VIA?
Yeah.
Okay.
I've worked with both. I've lived in the partners catchment area.
Okay.
Also lived in the VIA catchment area, serving both.
Okay, thank you.
I'm Paige Stevens. I work with Daymark Recovery Services, and we also, Daymark works with several of the MCO's partners, and VIA being two of them. As far as what I think VIA does well, to echo part of what George said, one of the things that I love that we're able to provide are the JJTC, the Juvenile Justice Treatment Continuum Services, and VIA works very well with us on that. One of the things that we can provide are intensive in-home services, which is a very intensive service for kids, and they fund us to provide that for children that don't have reimbursement, as well as those that do have Medicaid, which is a huge deal. I don't know of another area that allows that, so that's been a real bonus for us. In Alleghany County, they're now allowing Daymark to do placements in the hospital. They gave us some additional funding for that. So that's taken the weight off the hospital in a way that they could. As somebody said, we can't change the whole involuntary commitment system, but that was a piece that they could contribute to, and we appreciate that, being able to be of help to that piece of it.
Speaking of placements in the hospital and voluntary commitments, the worst place in the world for someone that's mentally ill to be right now is in our hospital. There's no appropriate room or suite for them right now. We're working with my long-lost cousin Craig James at the hospital. The new building that's going to be built will have, appropriate, I don't know what you call them, rooms, facilities, whatever, for the involuntary commitments, but we don't have them right now. That's the worst place in the world they can be, and sometimes they're there weeks, so thank you.
Clinic services about. You want to. One I just mentioned is concerned in some of the innovations that have happened within the last year. They have allowed IPS-supported employment to be in this area, which has been great. That's a wonderful program that puts value on people being able to work and how amazing that is towards someone's recovery and mental health. So we have people who are assigned to this area to help people look for work if possible, if they need education, using resources to try to help those individuals interested in furthering that to find a place where they can find that.
IPS, is that in-home placement service? What does that stand for?
It's I'm just drawing a blank for a second. Thank you.
Individualized
placement,
thank you.
yes.
Thinking
Exactly.
Iowa Polytechnic State, maybe. I knew it was a new member of the Big Ten. I didn't know. So.
Exactly. But that's been a new program that has been added to this area this year, along with the other enhanced services as well, ACT, intensive in-home, psychosocial rehabilitation, all of those things are there, and a robust substance use program as well.
I'm Becky Miller. We're from Alleghany County Group Homes. We represent the IDD population of the county, and we have been contracting with VIA ever since the beginning, from Smoky Mountain through the present. VIA has always been very supportive of our organization and of our population, and we really prefer to work with VIA.
Thank you.
Wes Starling, I'm also with Alleghany County Group Homes and Day Program. We serve about 25 individuals here in the county that have developmental disabilities, and whether they come to our day program or residents in our two group homes. It's done well. The thing that providers they have appear to be last several years. So they seem to be trying to stay on top of what those changes were, what it was going to look like. But I think they've done well. One of the reasons that we're here today also is to try to figure out also, I think we're all trying to figure out what exactly this new Medicaid transition is going to look like, both on the provider side, on the MCO side. And I guess when we heard about the meeting, that kind of piqued our interest to find out as far as exactly what the counties are going to have when it comes to the new changes, because it was kind of to my understanding that the state was going to award the contracts to certain entities to provide, to represent the old MCOs, and the old traditional MCO was no longer going to exist. So, and I thought it was going to be the individuals that chose who their provider was, and no longer it was the county. So we're here to try to get some of that clarification.
It was my understanding from my training class a couple of weeks ago that, of course, the tailored plans, which don't come out until 2021, those are most of your clients would be under the tailored plans. That they're going to be bid out every 3 years, like the Medicaid, you have Blue Cross and whoever the 4 providers that were awarded. The tailored plans are going to be bid out every 3 years. They told us the first wave, only the current MCOs can bid on those contracts. So Alleghany can only choose from one of the existing MCOs. At the end of that 3-year contract, it's bid again. Any qualifying organization, insurance company, anybody else can bid on that contract. So that's part of the decision. That's part of one of the key points of the decision that we're trying to reach. It's for the tailored plan individuals, because the MCOs, my understanding, will be handling all of their medical care, primary care physician, everything like that going forward. So that's one of the things I took from our training class a couple of weeks ago. Anybody with more knowledge, which would be most everyone in this room, feel free to correct me if I misstate anything. So
it will still be the counties that are making that choice, and not an individual that's choosing the MCO as kind of like the...
for the folks that will qualify for the tailored plan, yes. We will make a decision as a county that VIA, partners, whoever is going to be for the first 3-year contract cycle will be because that, again, it's only the current MCOs that can bid on that contract. So, yes, it'll be, so when we'll have more meetings with you guys, particularly as we get closer to a decision, certainly your input's going to be valuable. So, but thank you. Lisa?
I'm Lisa Osborne with Alleghany Social Services. We're just here to listen.
Okay.
I'm Tiffany Boyer. I'm with Alleghany in Motion. We provide the public and the Medicaid transportation for the county, and I'm just here to listen today.
Scott Perry. I'm the Chief Court Counselor for the Department of Public Safety, Division of Juvenile Justice. We are currently, the juveniles here in Alleghany, are currently direct recipients of the services provided by Youth Villages, Daymark. And since they've been involved with us, I think we mentioned like 7 years or so, we've been completely satisfied with the results that we're getting. And the juveniles have made some progress, and we're continuing to move on. So it's a good resource for the court to utilize to get services for kids.
I'm on the JCPC board. I make most of the meetings. I know the general trend the last year or two is our offenders are getting younger, right?
Yes.
We're 13-year-olds, 14-year-olds. Is that, yeah. How has that changed how VIA, the relationship with VIA, has anything, the fact they're getting younger, has that made a lot of difference as far as your direct relationship with your providers? Or?
No, again, they work very, very well with the age group that we have. Granted, again, yes, they are getting younger, seems like. Right now, statute says we can work with juveniles 6 to 18 years of age. And we're just seeing a lot of the 7, 8-year-olds. But again, the services Daymark and Youth Villages provide in terms of trying to do our CCAs and recommending appropriate services, spot on. Yep.
And one of the big parts of the criminal justice system is restitution. So we used to have the 15, 16, 17-year-old youth offenders, clean the courthouse and things like that. Can't really have an 8-year-old cleaning the courthouse making restitution. That complicates the criminal justice system even further. But that's another discussion, but thank you very much. So.
Hey, I'm Jennifer Green, and I'm here with the Health Department, App Healthcare. I think I'm here to listen too. We are also trying to learn and prepare for the Medicaid changes. So I think we hope that we've learned as much as we should, and I'm sure we'll learn more in November. But the only feedback I would have is we've had a good experience with VIA in the audits that they've conducted and the interactions with us. It did take quite a while to get our new provider credentialed, about 8 months. And I think that was a challenge for us, but we've worked through that at this point. I'm hopeful that with our next one, we won't have the same barrier. We, of course, don't do all this alone. We work closely with Daymark, and I think we plan to continue to do that. So I guess my interest would be just thinking about what's best for the county, and I think community prevention. So I wonder if there's if this is a MCO problem statewide, maybe there's not enough funding, or is it a MCO issue specific to VIA Health? I'm not sure, I guess, because I think some of the things that we're facing in our community are statewide issues because of just the system that we're in and the fact that we have an increased need for these services, and we have a limited number of resources to go around. So that's just our experience, and I don't know if you have anything to add, Kelly, but yeah.
I think we've got kind of a conflicting issues of, I think, there may or may not be more people in a higher percentage of the population in need of mental health services than there were 20 years ago. I don't know the answer to that, but certainly we're better at diagnosing it. Sure. Some of the stigma's coming off of it, so more people are receiving treatment. Now, again, there may be the same percentage of the population as it was a generation ago. I don't know the answer to that, but certainly there is more need. At the same time, the supply of providers has not kept up with the demand for services, and that's, again, we've talked about that earlier before you walked in, that's everywhere. That's not just here. So, but thank you. And your providers, are they in the office full time or here in Alleghany? Or?
Yeah, well, and we have one now that's split between 2 counties, but we've hired another one so we have one in both counties. We'll have one here all the time.
Great.
Hello, I'm Kay Loveman. I'm a licensed professional counselor, and through VIA Health, I'm considered a licensed independent practitioner. And I'm probably the only one who's down in the trenches in this county. I go into the homes and do family therapy because after all my years in the school system, that was the need that I really saw. Families need help. And so many families are dysfunctional. Children are having so many problems. And so I thought, well, in my retirement years, maybe that's where I could do the most good. And so that's what I do. I work particularly with younger children and parents, and we work on parenting skills. And basically, we train the parent as we work with the child.
He's also the chairman of our Juvenile Crime Prevention Council, doing a great job at that. So that's a thankless job.
I'm Pam Andrews, and I'm with Capstone Wellness Center. I have been providing mental health services in this county for 32 years as of June 1st. And I have been very invested in this county in the mental health, substance abuse, and developmental disabilities needs in this county for 32 years. So I'm here to listen and maybe share, depending on how the afternoon flows. And I thank you for this opportunity.
Thank you. All right, Nick and Robbie, you guys have anything to add to this point?
My name is Nick Hawks, Chief Deputy, Alleghany County Sheriff's Office. I guess the question on the table right now is, what is VIA doing well? I can speak that they obtained a grant a couple of years or so ago on some of the Narcan that we're carrying. They supplied us with about 25 boxes of Narcan that our deputies have been trained to use, and so now they're carrying it. So that was a great thing. I guess at a later time I would like to make some comments, or reserve some time to make some comments on involuntary commitments and treatment within the jail facility, mental health treatment.
That probably falls under the what needs improvement, right?
Okay.
So why don't you start us with that? I just want to say also that VIA brought me a box of Narcan a couple of months ago, and I gave it to the ambulance and the volunteer firemen and things like that. So.
You got any improvements? They're doing well.
So you want us to start on,
Yeah,
the voluntary commitment process in general is not great here, because we mentioned we don't have a good facility at the hospital to store them temporarily. We don't have placing them long-term's a problem, so go ahead, continue.
So one of the issues that we're facing is the amount of time that it is taking at our local facility to, one, either determine if these folks are meeting the criteria for inpatient treatment and being transferred to a 24-hour facility, or if it's outpatient treatment and then they're released at some point. Once they seem to be determined to meet this inpatient criteria, the time, and I know that this is even outside of Alleghany County issues, maybe in Raleigh, but the time that we have to sit with these individuals it's very hard when you're sitting 24 hours a day, 7 days a week on these individuals to keep staff for the county and things of that nature. It generates overtime by its nature. We're short-staffed, and so these folks, these deputies that's working, they're coming in to cover shift at the hospital on their days off, which is always generally on overtime. And it's hard when these guys work these modified shifts, 12-hour shifts, to get them back in to work these additional 12-hour shifts at a time. We just don't have a big pool of folks to choose from. So yeah, it's overtime, but it's also actually finding that individual that can come back in and pull those shifts.
And it really hits us hard, the moonlight shift, because we've got limited patrol.
It is.
And one of those people has to come off patrol and sit at the hospital with a mentally ill individual, then we've got even
Which
that
leaves
fewer
one.
people to patrol the whole
Yeah,
county. So.
and you know, our calls for service, we average roughly 29 to 30 calls a day for service. And throughout the day and the night, these guys, they get busy, they can get backed up on calls, and then they don't have the extra help to go respond. The day and time that we're living in, lots of times you need that backup, and they're not there and available. So it's security and risk that we have.
Mr. County Manager, I'm going to jump in here because I've got a number of questions. And before I start asking my questions, I want to give you my background so that everyone is aware of where I'm coming from. My wife was in a car accident whenever she was 4 months pregnant. That daughter was born with brain damage. She was institutionalized at age 14. We buried her on the 9th of February. Now, you say that you have a problem with the termination. We need to break this down. Is the problem VIA is not meeting your needs by responding in a timely manner?
So I don't know where I wouldn't say it's VIA. I wouldn't say that it's any other group. I don't know where the breakdown is in getting them placement. That is maybe we'll find out more about that today. I can speak to one thing specifically about weekends. I know previous years, several years ago, when I was directly involved with sitting at the hospital on a lot of these commitments, I haven't sit a lot in recent years, but now weekend placement no longer happens. If our deputies are sitting on a commitment on Friday afternoon, we know without a doubt Monday morning at the best will be the next time for placement. Is that locally because we're not getting the placement, or is that a state facility that is not accepting on the weekends? I don't know.
We're getting into a gray area now, because the first thing that's got to be done is a determination that they need placement. Now, that is where VIA comes in. I will tell you that North Carolina is at the north end of a southbound jackass whenever he comes from mental health facilities in the state of North Carolina, and that is from a user over 40 years, 30 years, excuse me. Now, we can't change that, only the legislature of North Carolina. But what I am very interested in, having sat with a child that had tried to kill herself for 48 hours, is I want to know, is a provider showing up to make that determination?
We know that there are providers that shows up at times at the
In
hospital.
a timely manner. How
Yeah.
about providers out there? What are you
Who
running
does that,
into?
George? Is that something you can do? Pam, is that something you can do, or is it certain providers?
And
that make that
everybody, let's
determination?
get in a circle and start appointing.
Can I make one
I'm
more
just
comment?
who makes that
So
determination?
from our perspective, we're not going to point a finger because we truly don't know. We know that we have deputies, they'll set them at the edge of the door, they'll see folks come, they'll see folks go. We don't know where they're at in the process until they say, hey, we're ready for you to go ahead and take them on.
Right.
So
Well,
we don't
what we've got to sit back here and do is make a determination on a provider. So what I'm looking at is, and I can understand your frustration. Now, whenever you get the call, we have someone that's having a mental health crisis, and you are called in, someone has got to show up to make a determination of what state this individual is in. Are we getting a timely response?
John, let me tell you, when I asked for people for community responses, one of the things that I have gotten in the recent past, I've had a couple with my ER doc for the fam, who said sometimes it's 10 or 12 hours before the first clinician shows up to do the first evaluation. Now, I don't know if that is an unusual circumstances or what, but they have come to me and said, we're really having a hard time.
Are
And
there
I
a group
direct
of,
them back to VIA.
there are a group of folks on call, kind of like the public defenders in the court system,
You know,
or?
granted, I haven't worked in there in a long time, but that's how it used to be,
Okay.
was you
And
had on-call staff.
that's my
Or
concern right
designated
here.
staff. And so I don't know if these were isolated incidents that really stuck out in these docs' heads, and they were like, oh, yeah, I remember this case, or if there's a trend. But that definitely is something that I would think Daymark and VIA could produce data on to be able to show, because I know that kind of data is collected, because we reviewed it monthly when I was working for them.
In fairness to them, if we have an event on the weekend, there may be 2 other events going on in Ash that they're going to have to respond to. Now it becomes a question of staffing.
Yes.
Now we are looking at the management of the provider. Now, once that determination is made that that individual needs permanent or 24-hour supervision, you know, that's where the state of North Carolina and their lack of provision for the mental health system comes in. We can't change
Yeah,
that.
and actually they track that
My
data, but they don't do
concern
anything with it.
is, how quickly can we get professional help to someone in crisis? And
It took
yes,
me-
ma'am, you're dying to answer, please do.
Go ahead.
As far as mobile crisis management is concerned, there is that's a team that Daymark does have. There is they have up to 2 hours. We don't try to make it on the 2 hours, try to get somebody to respond as fast as possible. And we do have data. I do not have that with me right now, but could certainly get that. The
Well,
clinician
now-
on mobile crisis does come to evaluate the person wherever they are, whether it's in the community, their home, at the hospital, wherever they present. That's where we will go to meet with that person.
Okay,
and
but
do an
now I've got a
evaluation.
disconnect. You're telling me that you can respond in 2 hours and I'm hearing 10. I've got a sheriff's deputy here telling me he's losing manpower for 10, 12, 24 hours, 48 hours, because nobody's showing up on the weekends. That's
That's not what he- I don't
unsatisfactory.
think that's what he said. I think what's happening is that the clinicians on the mobile crisis team are doing the evaluations and assessments for the needs of the person. If the person has been involuntarily committed or needs other services, they're going to be immediately trying to work across the state to find a placement for the person.
So you are telling me that you are having someone within a 2-hour time frame
That's correct.
that will come in and make the assessment. After
Yes.
that, it is out of their hands. It is availability of a bed somewhere in the mental health system in the state of North Carolina, be it Butler or wherever.
Yes, sir. The problem is that they will continue to make calls, continue to try to find that needed placement, whether it's a child or an adult, for whatever hospitalization or whatever care is needed. If it's facility-based crisis need, detox, whatever it might be. If they're turned down, they have to keep looking, and they continue to look until a placement is found. That can be time-consuming because the beds are short.
The sheriff's department's at the mercy of placement.
Exactly.
The actual
That is
assessment,
basically it.
on average, is that a 30-minute process, a few-hour process, the actual assessment, or does it?
It's as long as it is needed,
Okay.
as long as it takes to get a good assessment and and have those recommendations to follow up on.
Bobby, do you have a question?
I think it's for several of you. Let's look at the weekend. If somebody either commits himself, goes to the hospital, it's off their medication, whatever, or the sheriff's department has to pick them up and take them to the hospital. Now we're looking for a bed for these people for whatever reason, their psychiatric help or whatever they need. But those beds are hard to find in the state, from what I understand. There's a multitude of factors involved. Is that patient have other medical problems? Do they have other mental problems? And it's just not like finding a bed, in this county or this county that can take that person, but that receiving hospital that takes them has to be able to treat a multitude of problems that person may have. And sometimes it takes 2 or 3 days or longer to find a hospital that can treat all these. Every person's not the same. So you can't send them to one hospital.
Correct.
You might have a person that's diabetic that needs
Right.
special help. You might have a person with heart problems. It's not something that can be done overnight usually, but there are occasions that I think that the sheriff's department, working with the hospital, the health department, DSS, whoever's involved, within 2 or 3 days, they can usually find a place for them. But it puts such a hardship on this county because we're so small, we're so underfunded with the money that we can provide to VIA or to whatever organization that needs it. I think our contribution is right at $110,000, $115,000 out of 23 counties.
That ain't going very far.
It makes a difference. Now, let me say, I serve on the advisory board for VIA, for Alleghany County, and we represent 23 different counties. I've been there for 5 years, and I've really heard no hard complaints. There's always inconsistencies. There's always a problem trying to solve a problem. My biggest drawback that I've heard in these 5 years is when Vaya went from a one-on-one psychiatrist to a person who needed help, they went to a teleconferencing. And I understand the money behind it, but I don't understand the logic behind it. When you have a patient that's in crisis and you're talking to them over a television, I don't like that. But that's something that, I don't know if it's the future of medicine. If it is, I don't like it, but that's,
Even stroke care now, as somebody at Baptist will be on TV with our local physician here in the, even strokes are being treated telemedicine now,
Can I make one quick comment?
Sure.
And this is not directed.
You have the gun.
I just want to make a comment about these weights. And this is not directed anywhere in this room, it's directed at MedSpace, or how they come up with the reason to put one particular person in a spot and not another person, and I don't understand why this is. The system is not a first-come, first-served system. We will have patients or commitment folks sitting at the hospital, and there will be other folks brought in under IVCs that come and go before these folks do. I think looking at it from this individual's point of view, it's not the best arrangements or living arrangements there for them folks, and then the ER has a lot of other folks coming in and out. But these guys they spend long periods of time.
You've got to look at the mental health system. Whenever VIA makes a determination, they've got to be institutionalized. Now, if you have a violent person, that is one institution that may be able to handle a violent person, that they cannot take them because they simply do not have a bed. If you have someone that is suicidal, which has close observation, now who has a bed available? It may be in Butner. I can't remember any of the others. I've threatened to write a book, Mental Institutions in the State of North Carolina, Do's and Don'ts, because I think we hit every one of them except Dorothea Dix. That is where the lack of facilities comes in. The only thing that we can really affect is the initial assessment, because after the assessment is made, then we go at the mercy of the mental health system in the state of North Carolina and the availability. And you cannot transport and relieve that deputy of that responsibility until we can get them somewhere. So if VIA is meeting the needs, or there's another institution that's meeting the immediate needs for assessment, then that's something that we've got to take into consideration if we have to make a choice between two providers in the future. And this is where my personally, I want to make sure that we get that psychologist there to make the assessment so that we can start the process. Now, if we're waiting for 6 or 7 hours before the initial assessment, that, in my mind, is too long. But I've also got to look at VIA. There's so many people that can do the assessment, and they're covering multiple counties also. So, whenever you start looking at this, I think it would be easier to start looking at 2 women and a baby between them and figure out who's going to get which half. That was biblical. And believe me, I've been there. I know where it's at, and I feel for these people, but I also have an empathy for that mental health patient that is there needing this service. And we've got to do that provision.
If someone is a substance user, for example, and we have to pick them up for an IVC, those people generally are unhealthy. They don't eat right, they don't exercise, they probably smoke, they they don't get regular checkups, they're unhealthy, they're unwell, and that
You have
complicates,
hepatitis C,
complicates
they
where
have
we, yeah,
HIV.
hepatitis, well, complicates where we can send them as well, just another complicating factor, so.
Let me ask this one question, and I just want to be sure that what I've been told is the way that it happens. If a patient commits himself to the hospital, they can uncommit themselves within 2 or 3 days. They don't have to have a doctor that releases them, is that correct?
As long as they are not a danger to themselves.
But if you have to arrest somebody, then they have to be examined by somebody at the hospital, and that person says that they need a bed for X, Y, or Z, whatever the problem is. So the assessment, the way I understand it, there's 2 ways to be assessed. There may be more, but there's a lot of pressure put on our county, our hospital, or whoever does that assessing versus the person who turns himself into the hospital. And I think that's adds to the overall problem. If patient A says, I need help for 2 or 3 days, then I'm out of here. You've got to provide security. The hospital has to provide what care they can provide. It's a complicated situation.
Nick, in your point, have you ever asked VIA why yours got passed over and someone else's got dealt with?
No, I think I understand that, because
You should.
just like Mike said, I completely get that people are at different levels. I think that maybe insurance has had something to do with it. These folks that got
Money's always a factor on every decision in life, so.
There's always rooms in private facilities, aren't there?
I understand, I made the comment just so that I didn't know if y'all understood that these folks sometimes are not a first come, first served. I didn't know how much y'all are aware of that.
There's always a room available at the Betty Ford Center, right? $1,000 a night, so.
Bring a checkbook.
Okay. Amanda handed me the mic back, so I guess I'll talk for a minute again. The things that need approving.
I didn't know if you could respond to his question or what he was discussing.
Well, in the voluntary, it's touchy, because if somebody gets to a hospital and the doctor deems them unsafe.
Gotta hold that real close to your mouth there.
If somebody gets to a hospital and the doctor deems them unsafe, then they won't let them leave. They will put them under commitment, so it varies. So, yeah, okay, you can talk now. Okay.
It's been a while since I've worked in that area. I just want to make a comment or provide some info on the care coordinator side of working with an MCO and regarding commitments to emergency rooms and trying to find inpatient facilities for these people to go. As a care coordinator, whenever somebody, and I don't know if VIA is the same way, but as a care coordinator, this is with partners, if somebody is in the ED for more than 48 hours, we are contacted and a care coordinator is assigned. From that point, the care coordinator is in communication with the parent, with the doctor, with DJJ, with law, whoever is involved. We are in communication within 24 hours with those people, and we are helping the providers to find their inpatient placements. If one isn't found, utilization management through partners is on the care coordination's butt. Well, why hasn't a placement been found? What have you tried? Who have you called? What's being done? And so maybe they can provide feedback on that service. I know that's been a complaint in Sparta. Our providers, our physicians in the ED have made the comment they don't communicate with anybody from VIA with assisting with placement. And so I just kind of wanted to throw that out there. That's where partner stands on that. That's part of what I assist with. So I don't.
Do you work with partners? Someone with VIA would like to comment on that?
Yeah, I'll comment on it, and I just wanted to add to
the conversation around involuntary commitment. Hey, most folks know me. I've been here often. Brian Shupin with VIA Health, Senior Director over County Relations. We do cover 23 counties, work closely with the County Commissioners Advisory Board and some of those different groups. Just wanted to comment on kind of our process with the hospital. We met with the hospital a few months back. One of their big issues was the hospital doesn't have a social worker for placements. So then it puts Lori and the other folks in the emergency department trying to do that along with seeing people that come in. We've put a contract in place with Daymark to do that placement for them. We're doing this as a pilot. We don't do this in other communities. Our care coordination does similar things in hospitals. Jimmy Poplin checks in with the hospital, sees, what we need to do to assist or how we can help find placement. So it sounds like it's pretty similar. And if I may, I just wanted to add a few things about the IVC drop-off. We've established the IVC drop-off and I'm sensitive to law enforcement's travel time, but in Caldwell County, where instead of going to the emergency room, you can, go there and they take custody. So, versus staying days, you're traveling a little bit to do that. We also have one in the works that's being developed right now in Wilkes County. I think it's about 40 miles from this hospital there, a little further travel time with the road. But we have 4 of these now, or we have 3 now across our 23 counties. We'll have a 4th. Have 2 in relatively proximity to this area here. So that's a real resource where, once you're there, 15, 20 minutes, law enforcement releases custody to the site and then can go back to work. So just wanted to share that as that conversation was coming up.
Is that available to us now?
Caldwell County is available starting May. This is May, right?
Yeah.
This is May, in May,
Okay.
and then Wilkes County will be next.
So we don't necessarily stress the travel. We are delivering these folks to these facilities, Jacksonville, Wilmington, Clyde, and everywhere in between. So a Caldwell County trip for us is literally like driving to Sparta. I mean, from our home. That's nothing for us. So if I understand that correctly, they will go to the hospital for an initial, and if they are determined to meet inpatient criteria, at that particular time, we could load these individuals up and drive them to Caldwell County?
And I failed to mention something. Senate Bill 630, we're having a call about it Friday with the county managers. Senate Bill 630 is looking at alternatives for the first evaluator sites other than hospitals. So Senate Bill 630 was the #1 priority of the Hospital Association, which is looking for alternatives for first evaluator evaluations. So in this community, we would be identifying where would that be? Would that be Daymark during their operating hours? Would it be, facility-based crisis? And this is just for IVC. It goes along with the counties having to either reestablish or make sure that their IVC transportation plan's in good shape. It goes in connection with the IVC crisis plan. So, yes, Shirley Randleman, Senator Shirley Randleman, got money for a regional facility in Wilkes County. She got about $1.4 million. We're in the planning of that now. Bias put substantial funds into making that whole. You can't do one of those facilities for $1.4 million, but it'll be obviously drop-off site for this region.
Is the Caldwell County site up and going now?
You know the May date, Carl?
It's in place.
Right.
So,
Can you send us some more information on that?
We can do a tour for the sheriff and law enforcement. We offered it to, at the crisis meeting.
Sandra.
Yeah.
Just clarify that. Okay, so we get an IVC. We pick the respondent up. We take them to the hospital here to be evaluated at this time. They deem them committable to a 24-hour facility. At that time, instead of these massive waits that we're having, as soon as they are deemed committable to a 24-hour facility, we will load them back up in the vehicle and transport them directly to Caldwell County now.
Given they have a bed available.
And there's somebody that can
And now, that's good conversation. Nick, you guys can continue that after the meeting. Let's get back. I mean, it's good discussion. We want to we're okay to get into the fringe, but we don't want to get all the way into the rough. You know, we want to try to stay on the fairway if we can, so.
What I want to do is talk a little bit about the last couple of years that we have dealt in the system. I think Daymark does a good job. I think they've got very limited resources. Youth Village is coming here. They were in Boone when I was still working. They were based in Boone, and we're starting to kind of come over this way. But with all the things that have been discussed that are in place, we still have a tremendous shortage of mental health services here. And people are going without care, and people are dying from it. The only place I can get the psych testing done that VIA will pay for is in Asheville. They will not contract with a provider in Winston-Salem to do the testing. And so I will have to drive 3 hours because Medicaid transportation will not provide transportation to Asheville because there's a provider in Winston, even though I can't go with my Medicaid. Take a 6-hour battery of tests and drive 3 hours back home. I have rheumatoid arthritis and most of my spine is destroyed from bone loss from it. So riding in a car for a total of 6 hours would be a nightmare. Okay, so I have a son with autism, diagnosed at North Carolina Teach Center. He was diagnosed when he was 12 years old because he's high functioning, but he was diagnosed to be moderate to severe autism on the spectrum. He is in mainstream school. I have worked with him for years, and those of you who know him would probably say you never knew he was autistic. But VIA denied services for him because moderate to severe was not profound enough to qualify for autism services. He's almost 16. He's going to be 18 soon. He wants to go to college. He can't manage money. He can't keep himself safe from being exploited by others. He can't manage a household by himself. But VIA says he's fine. He doesn't need anything. So we don't have any services for him except what I'm doing for him right now. My daughter has profound anxiety, severe at times, and she has obsessive compulsive disorder. And those of you who remember Camille know she has an extensive physical health history too, and has been through more than any child should have to go through. We were at Daymark for services for a long time, and it got to the point that most all of our appointments were canceled, and we had gone for about 6 months without seeing our doctor, and we finally decided I needed to find someplace else to go. We went to a doctor in Kernersville, driving that far to see a psychiatrist that treated children in person. When we went on Medicaid, VIA would not do a single case agreement contract for us as a family. And Kernersville would not contract with VIA because they were already contracted with other MCOs in their area, and they didn't want to contract with another one to have to jump through another set of hurdles and hoops. So we lost our doctors. We went to a provider in Wilkes. She put my 14-year-old on Xanax, and we learned that she was also prescribing medications illegally in North Carolina using their Medicaid contract with VIA. Obviously, I took my kids out of there, especially the 1 milligram of Xanax 3 times a day for my 14-year-old. My children right now don't have any care. They're seeing, Dr. Bryant's doing my son's medication, and my daughter's finally seeing a therapist right now, but we have no source for medication for her right now because I won't take her to the provider I'm going to in Lenoir. The provider I go to in Lenoir, I'm allowed to see for therapy once every 4 months with my Medicaid. I can see my doctor once every 3 to 4 months. The last time I went a week ago, she was playing on her phone for about the first 5 or 10 minutes, talking to another doctor. And then she started telling me about how overworked she was and how stressed she was at her job, and that there really was no services up in this area, and that VIA really needed to do something about that, and that they would love to move up here. And she spent 30 minutes telling me all about her life. She never once asked me how you're doing, how's your meds, do you need refills, nothing. That's my care I'm getting right now. I refuse to take my children there. I don't leave my house anymore. My anxiety is so bad. To be here today has taken everything I have in me because I don't go out anymore. I am terrified to be in spaces. I'm terrified I'm going to say the wrong thing because sometimes what I think I'm saying coming out of my mouth is not what comes out of my mouth. So these are the reasons why I say VIA, I think, does a good job, and Daymart does what I think is a good job. But Daymart can't get staff hired for whatever reason that may be. They have the hardest time having staff. Nobody wants to come to Alleghany County and work. That's a lot of it. I realize that. But there are options with partners because that opens Surrey, Stokes County up to us. Providers in Mount Airy, providers in Dobson, providers in Wilkes that we aren't able to see right now. The providers in the Elkin side, I'm thinking of the Surrey County, not Wilkes. But we have options that would be available to us. Or at least I'm not driving to Lenore to see somebody who doesn't give a flying flip about me or whether I'm doing fine or not. I also wanted to throw in that I was in crisis in October last year. I was extremely suicidal. I had a plan. I had access to it, and it's only by the grace of God I'm still sitting here today. It was 3 days before Mobile Crisis could respond, and I had to meet them in Lenore. They would not come to see me here. So this is what we have here in this county right now. Okay? I had one friend who said that her daughter was on a waiting list for 2 years to see a therapist at Daymart, and she ended up pregnant at 17. And she just had a beautiful baby boy a few weeks ago. I have another one who has gone to the same providers I am. She has intellectual and developmental disabilities, and she can't fight to tell these people to stop doing things. And that same doctor that put my daughter on Xanax put her on Xanax and Valium, on top of the fact that she goes to a pain clinic, is on tons of opiates. She could die at any time because of what this doctor has done. There is a child who died about a year ago. His mother had waited a year on a waiting list for services for him, and he committed suicide about a year ago. And there have been others who were profoundly mentally ill, who are struggling every day, trying to figure out how to do. They're going without their medications. They're going back to using street drugs because it's all you can find. And they're trying the best they can. I have people show up at my door. I have people who call me. I have people who message me on Facebook begging me to come back to work, begging me to help them find something because they need help and they're miserable and they're suffering. We need more options here in this county of care. There's just got to be more choices. And the last thing I want to say too, and then I'm going to stop. I worked for VIA for 5 years. I loved working for VIA. It was my favorite job I've ever had in my entire life. So I will not ever say anything bad about VIA. But there's problems. There's problems with anywhere. But one of the things I used to always fuss about, and I'm sure they have heard me say this in meetings, is VIA is very Asheville-centric. The center of the universe is Asheville. Their corporate offices are there. They're doctors that they think about when they write policies, and they are based on this big city. Partners is closer to Winston-Salem, and so when these ACO things get up and running and we start having to roll with it, if we stay with VIA and that direction, we're going to be pushed more towards medical providers in Asheville, whereas I think if we have a partners option, then we're going to be more likely to fold over in with Winston-Salem, where our folks go for specialty care. And so I think that's something to sort of think about as this unfolds, and that's just me looking at the big picture of what may come down the pike.
Thank you very much for sharing that personal information. Let me ask a question with my economic development, workforce development hat on. If we had 5 licensed clinicians that wanted to move here tomorrow, are we capped because of our population and how many folks you can certify in the county? Absolutely not. Okay. And was it George, right? Was that your name? Dallas. Dallas, I'm sorry. I called you George earlier. I apologize. So, you're fairly new here, you said? Yes. Are you making a living? Do you have business? Or?
I also have an office in Elkin.
Okay.
So I'm between Elkin and here.
Mm-hmm.
It's been a very slow start here, just
Okay.
kind of getting to know folks and get my name out. And I do a lot of specialty work. I do mostly trauma work with children and adults. I also work with children with behavioral stuff, and it's strictly individual outpatient therapy. And I'm making strides right now to try to hire another clinician, but that's been a challenge for me, is to find someone to come and do the work, which I'm sure a lot of the agencies that are represented here also face that same struggle. So, you know, I'm hoping to continue to be in this community and do as much work as we can here.
Counties and towns from time to time, you know, have helped hospitals recruit doctors, you know, funding retention bonuses and things like that. I know this county did it several years ago with a couple of veterinarians. We had a veterinarian shortage in the county, and we gave $10,000 or $15,000 to a couple of veterinarians to get them to move here. So if again, all comes down to money always, but certainly if that's some small piece of the problem that we could put a little money into and address, I mean, that's something we would certainly consider. I think we would require board approval, but we'd be interested in at least exploring something like that if that's, I mean, one thing to any folks we try to recruit into the county, you know, they need a place they can work. You have to kill everything you can eat, right? You get paid based on if you don't see anybody today, you don't get paid today, right? So we want to make sure that they can make a living. It's a great place to live, cheaper to live here than most places, so maybe you can see one less patient a day and do just as well as if you were living in Winston and seeing a couple of extra patients a day. So, I mean, again, that may be something that we could study. Maybe there's some option there. I'm just, you know, again, just different ways to attack problems, but shortage of help is a problem in many areas, not just mental health right now. So,
Somebody enlighten me, please. We will roll this out in Region 2 and 4 on November of 2019.
that's the Medicaid transformation.
That is the
yes.
Medicaid transformation. Now, this is affecting what we're going to do. Now, Region 2 is Watauga, Ashe, Alleghany, Wilkes, Surrey. So the western part of the state's down there, you are not going to be referring people down there, are you? Because you're going to be out of your service areas.
Yeah, hey, my name's Donald Roos with VIA. I'm with our Provider Network Department. Just to clarify that, the health plan regions that you're looking at are for the standard plans within the system. So those 6 regions were put in place for what the state wanted was provider-led entities. The state only chose one provider-led entity as a contract. So technically the 4 statewide plans don't look at that map at all. It doesn't apply to them because they're operating all 100 counties statewide. The map that the tailored plans will be operating on their regions is yet to be produced. And that's part of the conversation of where the system will go. What counties will be on that tailored plan map will be produced later in the system, because ultimately, just like a provider, there has to be enough Medicaid individuals in a plan in order for a managed care company to operate. So
You just simplified it. Yeah. I'm being facetious.
Sorry about that.
The state is very good about telling us 3 years from now we're going to change something, but then 2 years and 7 months later, they haven't given us any more information. The state's very good about doing that kind of thing, so.
So we're basically looking at two different plans.
Yes,
Two
it's
different
really 2 different things. And just to answer the question about medical services, because the tailored plans have to contract with a standard plan partner as part of that, is that on the medical side for those tailored plans, you'll have statewide access to every medical provider that's in the network for a Blue Cross Blue Shield, a United. There isn't going to be any restrictions to that. And even with partners territory, we don't just operate in our 23 counties. We have contracts with providers across all 100 counties. We have contracts with providers in Virginia and Tennessee, Georgia, Florida. Most of the providers in the partners network are in our network. So there's really no issue for individuals to get services from Burke County, Surrey County, any of those partners counties. We have them in network in our system already. So if there is challenge to getting that, we would just want to know about it, because we definitely don't want access to be an issue with transporting. we try to contract with every provider we can in order to get the right access. We have every hospital under contract that we can, and every facility-based crisis bed that we can find and contract with in the region. So even though we're a 23-county region, our network is significantly larger than 23 counties. It goes we cast the net as far as we can.
But with the state line issues, we don't know how with the Medicaid transformation, we don't know all those answers. I know I sat next to the Avery County representative in Durham, and they were grilling the secretary on state line. Because in Newland, you're much closer to Johnson City than you are to any city in North Carolina by far.
Right.
Which is Johnson City's my hometown, by the way. But that's what they were concerned about, Medicaid transportation across state lines. I mean, we don't know. We don't know what we don't know at this point. So.
Yeah.
And that's the tailored plans are the ones that take effect in June or July of '21.
Yeah, so they're
we don't know
2
yet.
years out.
Yeah.
Yep.
Are any of y'all experiencing cutbacks in services at VIA as a result of funding or just discontinuing them?
Well, when you say funding, we have Medicaid funding, and then we have uninsured funding. So as far as from the state goes, the state General Assembly has been cutting single stream funding for the uninsured back every year for the last 15 years. So we did a study, and be glad to show it to you. Over the last 12 years, they've pulled over $100 million, out of our system alone that used to go to uninsured funding. We've been trying to backfill that as much as possible. And again, we can show you some data on that. Per dollar, we serve more individuals for that money than any other MCO in the state. We have the highest penetration of uninsured people served for the money we receive on the Medicaid side as well as the uninsured side. So yeah, the funding's getting less, and when it gets less, we have to get more creative on stretching that same dollar further, and that's the challenge. Sometimes you only can stretch it so far, and then a dollar breaks. But that's what we get. There is a bill in the House in this session where they're looking to restore some single stream funding. We definitely would support that, encourage people to talk to their legislators and support that as well. All that money goes directly into services in our communities.
Any commissioners, any other questions for anybody right now?
I think Dr. Khan wanted to say something.
I was just going to say North Carolina Medicaid has always discouraged recipients from crossing state lines by not paying those providers at the same rate that they pay in North Carolina. So good luck with getting them to Johnson City.
Our friends in Avery County, yeah, good luck to them.
Yeah.
I'd just like to thank everybody for coming. It's been very informative, and we have to make a tough decision here in the next few weeks. You all do a job that very few people can do. And you go home at night and you try to forget it, but at 2 o'clock in the morning you wake up and you still remember what you did that day. And I thank all of you for that.
I'd just like to echo the same sentiment. I'm a little behind on mental health issues, and I've enjoyed this meeting. It's been very informative, and the gentleman talked about the new facility down in Wilkes be a central. Maybe that'll help relieve some of our stress on our sheriff's department and their deputies.
Concerned about bed space because when you said 12, what county?
Please.
Adding beds, we're working on a new initiative in Alexander County on basically creating a new psych unit in Alexander County specifically for IDD diagnosed individuals. There's not one of those in the state right now that's in that. So we're working with Alexander County around that because those are the ones that get stuck a long time when they have that low IQ and nobody wants to touch them in our hospitals. We're working with the facility right now that's going to build a facility from the ground up. In Alexander County, which will be another resource within the system.
Paige had a comment there on the waiting list. Go ahead, Paige.
Thank you, and thank you all for listening today. We do appreciate it very much, appreciate the concern. I wanted to speak to the idea of the waiting list. There have been times that there's been a waiting list. There have been occasions. We do not have a waiting list and haven't had a waiting list for quite some time now. We just had a discussion, in fact, about high-risk children with youth villages, actually. So if there's a chance that, or a child that needs an enhanced service, for example, and they have an opening and we don't, or vice versa, then that child is referred through JJTC. So it is very quick to turn around. It's something we track weekly, monthly. We look at it in our meetings, so we don't have a wait for services at all now.
I like calling you that.
We got a question about the mental health with the jail. It may be something Vi can answer today. You know, they'll come out in times of crisis. You know, somebody's on suicide watch, something of that nature. It seems like I think we're transporting inmates to the hospital. You know, they're pretrial detainees. Most of them, you know, we're holding some to the state. And my question, will they come out, you know, I think we're transporting them like if it's not a crisis. You know, if they're not at that point in their crisis that they're trying to commit suicide or they're on suicide watch, and will they come out to the jail, you know, to assess the patient? You know, it puts us in a situation where we're taking individuals out, transporting them, then it's putting jailers, deputies, hospital staff at risk, you know, taking them up there. You know, maybe even I think we've ended up transporting some inmates in the last couple of months, maybe to some appointments for mental health. You know, I know we keep going back saying in the old days, you know, I just remember, you know, 10 years ago, anything to do with mental health, we had folks coming in, which at that time I didn't pay attention, don't know who. You know, I was just a jailer working in the back. Somebody comes see an inmate, you know, or is it a policy or something Vi's got that they, you know, they only come out for the crisis situations? Or
Do we have a good spot in the jail for that exam to take place now? Because our jail's kind of was designed a long time ago. It, you know, doesn't have all the modern amenities necessarily. So
right, we have a large cell. I mean, we have a large cell.
so we can keep
keep
the provider safe and keep the inmates' privacy and that kind of thing.
You know, looking at it, we've got a single, you know, a large cell. The jailers are standing by. There are going to be more officers at the jail. You know, you're going to have 2 jailers on duty. You know, in those situations, you know, we can pull, you know, we'll have a road off, you know, perhaps to pull road officers, not a 3rd jailer there. It's privacy cell. You know, that's the cell that lawyers use when they come in and, you know, talk to the inmates. That was just, you know, a question, because I feel like it's putting, you know, the security at risk with the officers transporting them plus the hospital, you know. So I don't know if that's a policy or...
Well, I mean, again, from a unobserved bystanders, but one person coming to the jail makes more sense than 3 or 4 people from the jail going somewhere else, if that's feasible.
Right, and determine what their charges is. You know, if it could be a high-risk inmate, you're taking a couple.
Is that something you guys can address, or does that need to be homework for later, or?
We try to talk a little bit about that. Jail services are always exciting in each of counties on how to provide those. The state dollars we get from the state technically can't be provided for a person in the jail, but we get very creative around how we do that. One thing I was asking Brian here whether you guys were committed to the Stepping Up initiative for the county. That's one thing that we start with talking with counties around. That's an initiative around, first, how can we keep those individuals out of your jail to save you money and then having to necessarily do treatment into jail. It's always better for us to find ways to keep people out of your jails. So we've invested in what we call sequential intercept mapping. It's a national model that they use to come into a local community and really map out all the intercept points. Brian here is a trained facilitator for that. And so through that, we can identify where in the points of your intercept for law enforcement would be the best place for us to insert an intervention to keep that person out of your jail or to get them back out of your jail. And that's not only a conversation with law enforcement, it's a conversation with your magistrate, your district attorney, around those, and what's the tolerance level around us diverting these people out of your jail systems and into treatment services? Because if we can divert them out, we can pay for that all day long. So that's a win-win for the system. So we're completely open to sitting down, having a conversation, getting the right people at the table to have that conversation, make sure everybody agrees what the plan is, and putting it in place. And we're doing that in multiple counties, large counties as well as very rural counties, on how to make that work. And it's very different, depending how the system works. But
My question is about, so you're talking about, depending upon, like, if we have somebody, just for example, somebody says, I have anxiety,
Right.
or they not come to that question, says, I'm suicidal,
Right.
Anxiety person will still be treated, we would still, put them on watch, but it's,
Right.
Not as intense, it might be a 30-minute round as
Right.
opposed to a 10 or 15-minute watch in a county cell with a suicidal person.
Right.
My question is, do y'all come out, would you come to the jail if we have a jailer, the shift supervisor calls, captain calls, says, hey, that guy needs, talk to someone?
Yes.
Is there a set of circumstances we can put in place to where you could routinely come out to the jail?
I understand your concern about keeping them.
Yes, so the answer is yes. The way we have to do it is braid the funding, right? Because once the clinician steps into your jail, they're not allowed to bill Medicaid or their funding source for that service. So for a provider to do that, they got to have some supplement around that. So that's usually a conversation of, can we work with you in the county to where we can cover that person and then hopefully get that person out of the jail quicker, because as soon as we get them out, the more we can cover their cost of it. But, it's very doable. We would want to look at your jail health plan, that you got in place. There's some requirements around that the county's supposed to have around the jail health plan, and then figure out what's the best solution for your particular county.
Citizens love the thought of spending their tax money on mental health counseling for jail inmates. They love that.
I'm not going too far back in depth on what Chief Nick Hawk's earlier question was. On the weekends, it might be a miscommunication with the sheriff's office, the hospital, and the providers. Are they somebody, on like 4 o'clock on Friday evening, during normal business hours, somebody says, or, y'all come in, this person needs further treatment.
Right.
On 12 o'clock on Saturday, lunchtime, not normal working hours, other than folks important that's on call. Are you all the ones the ones that's looking for the beds? I mean, are they, like, is the state saying we're not opening up beds on weekends? Or is that the hospital looking for the bed? I mean, who's looking for that bed, like, follow up? Because I don't know if there's, we've always heard this from the hospital saying, they had a bed here, they in Jacksonville, nobody followed up on it. I don't know how much, that's our question, I think it kind of went a little bit different way than what Chief here was saying.
Sure.
We used to routinely transport to 24-hour facilities on the weekends. We haven't done that in a number of years.
Well, now, that was our question, kind of went a little south when we asked the question.
Yeah, all of our facility-based crisis units are open 24/7. They never close.
So you have somebody on call that comes up?
Are they actively working for placement on those weekends? Because I don't think our guys see anybody.
Well, I was talking about our facility-based crisis. They're the ones that you'd be transporting to. They're the IVC designated facilities.
Okay.
They're open 24/7. The hospital with Daymark would be looking to identify the beds so you can transport them to those particular facilities. And Daymark's team would be responding on the weekends and doing those assessments. They're not taking the weekends off or anything like that. They're 24/7 response to the ED.
We were just trying to figure out how, 10 years ago, I remember I'll give up a lot of Saturday nights, Sunday nights, Sunday mornings to transport somebody. And then, it's all of a sudden, if they're there, if they're deemed they need to go somewhere else, it's like, well, we don't even put nobody on call to take anybody anywhere. It's on call to sit at the hospital. That was our question. We thought maybe, we thought that either there's something come in place with policy or law that says You know, these places can't take them on Saturday,
No.
and Sunday, you know.
There really shouldn't. I mean, and you guys are asking all the right questions. This is what everyone in the state's trying to figure out right now. It's what Senate Bill 630 is all about. When, you know, we come out to your community in the next month or so, this is what we're going to be trying to figure out with all of our communities, right? Is where can we do, what can we do differently to do that? One of the helpful pieces of that bill, it expands the type of people that can actually do those assessments. Right now, you have to be a psychologist or an LCSW. You know, those are harder to find, especially in rural counties that does evaluation. Senate Bill 630 expands that to LPCs and LMFTs, licensure types, which they're still hard to find, but a little bit easier to find in rural communities. So we would expect to be able to add additional evaluators in each of our communities. Right now, we have the most first evaluators trained in the state in Western North Carolina. The challenge is the state is the only one that actually provides the training. So it's sort of a funnel of getting people in and trained to do those evaluations. But right now we have those available. Daymark's doing them. They have trained certified people, and hopefully we can continue to expand that.
Some of our patrol guys are saying that they're not seeing the tell us, is that something?
Yeah, I mean, telepsych, I mean, I know it's not the ideal. It's not the ideal for me either, but it is the way that the system's going.
Was that for folks with Medicaid or or was that?
Yeah.
With
Yeah.
insurance?
Yeah.
But at one time, I was thinking from the hospital staff was saying, that's nothing on paper,
Yeah.
that's just here, and I was thinking that folks with insurance got treatment that folks without Medicaid, that always kind of bothered me, thinking,
Right.
Faster, but I guess it goes back down the
Yeah.
money,
Well, all the law enforcement's having this conversation right now, and I can tell you even some of our rural counties are looking at the Charleston model. Charleston has a really unique model that we've looked at to where the first evaluator is actually telepsyching to the patrol car. So the officer actually don't have to transport them to the ED or anywhere else. They basically have the person in their patrol car with their laptop. They do the first commitment eval, wait right from the patrol car, identify them, the person's working on the placement for them, and the transportation plan from there. Now, there's still a lot of things to fix in some of that plan, but that's sort of the outside-the-box thinking that we hope to do in all of our communities to try to figure out what's going to work best for you, your community, around trying to make this better. Because it is a log jam. The number of beds, what's available in the system, and we have to figure out how to divert people to some of our other resources. A great example is we have a child facility-based crisis in Asheville. It's on one of two in the state. Empty beds there today, right? We know, but there's children sitting in EDs that are waiting to be dispositioned, but those EDs are trying to find a community hospital bed and don't want to disposition them to a facility-based crisis. Those are the challenges, we have as an MCO, is trying to really identify those and get those individuals diverted to the right services, which frees up the higher-end beds for the people that really need them.
You found a workaround yet for the hospitals requiring the medical clearance? Because I know that was always the hurdle.
Yeah,
too.
so Senate Bill 630 addresses that. They actually require a medical health screening. This is being highly debated in the state too right now because the health screening is done by the first evaluator, which is an LPC or an LMFT, and they're saying, hey, can an LPC really do a health screening? In reality, yes, because it's going to be like a 6-question questionnaire, yes or no, trained on it, where they can evaluate people with a minimal health screening and then move them on. The full medical clearance would be done at the second eval. Yeah.
All right, thank you. Does anybody have a salient, relevant comment you can make in a minute or so?
I'll just read mine then to make it real quick and precise.
Thank you.
Real quickly though, again, I'm a clinician, been working in this county for since 2010. And the reason I'm here advocating for y'all to consider another MCO is specifically for the people in this community. I gain nothing from partners coming in except probably more being overworked more, because that's what I'm doing now. And with partners coming in, I couldn't be a clinician in this county under that MCO, being a employee of that MCO. But real quick, I just kind of want to read this because if not, I'll start getting off track. But like I said, mental health counselor here since 2010, care coordinator for partners for the past 4 years. And of course, they manage Burke, Catawba, Cleveland, Gaston, Iredell, Leakin, Surrey, Yadkin, and now Rutherford, who recently added to us. We're contracted with over 300 plus providers in North Carolina to meet the needs of our consumers. We're also contracted out of state as well to assist in meeting the needs of members when in-state options aren't available. And as a care coordinator, I can attest that if we can't find a placement for any of our youth, and I find somebody out of state, they jump on it like that and try to research them and get a contract in place so that we can get those people services. And so, like I said, I have a passion for ensuring that the people of this county are getting the services they need. Over the past several years, I have seen the need for mental health services continuing to grow in Alleghany for children, adolescents, and adults. Alleghany County has been designated as a mental health professional shortage area by the U.S. Department of Health and Human Services, and I have that data to give you after this meeting. This means that we are an area, of course, with too few providers to meet the mental health care needs of the population, yet claims have been made by our current MCO that additional medical providers are not needed in our county. Unfortunately, the children and families of this community are the ones who end up paying the price for this paradox. Where there is a shortage of providers, people are less likely to get preventive care. Because of this, mental health care is often seen as the last resort instead of a preventative measure or an ongoing program of therapy. That can have devastating consequences because the problem is only treatment when it becomes a full-blown crisis. Currently, Alleghany County does not have enough provider capacity to provide adequate counseling services. There are long wait periods to get consumers or families into outpatient counseling services. Consumers could better benefit from more frequent counseling services versus once per month visits and long wait lists. I've heard from numerous consumers and county stakeholders that many are often seen biweekly or monthly, regardless of their actual need, due to limited services. Families do not wish to use Daymark. Those who do not wish to use Daymark have no available alternative for outpatient therapy within the county. Now, we have him, which, congratulations. Therefore, consumers are often referred out of the county to receive services, which often creates a problem regarding transportation for the individual as discussed. A little over a year ago, 20-plus letters were gathered from Alleghany stakeholders, Dana, DSS, Partnership for Children, the Sheriff's Department, the schools, and these were provided to via MCO, and because they had said we didn't need any more providers in this county, and it was ignored. We still didn't get the providers, and this was a little over a year ago. Now we finally got Dallas. They did allow him to come on. These letters, so they were provided.
The new provider at the health department as well.
Yeah, exactly, the health department. But as an employee of Partners, I can testify that they work in collaboration with county government officials and local stakeholders to develop plans to invest those taxpayer-provided funds. They provide a transparent accounting of uses of those funds to the county leadership and respond to wishes of the county they work with. Leadership and staff throughout Partners are engaged in relationships with their communities, active collaborating with stakeholders, providers, consumers, and others to meet the challenges faced in those counties. Our county needs an MCO that will provide more providers choice, more frequent services to meet individual treatment needs, less wait time to receive initial services, more support to assist with ED crisis needs, and someone that will work with our ED on decreasing ED length of stay. I am one of 4 partner employees that live in this county. I'm not sure if VIA has any employees in this county at this time. Unfortunately, one other was unable to make it here on time because she's assisting with Rutherford transition. But I've seen firsthand the needs in this county, and the passion that Partners employees have for ensuring that they are as supportive and transparent as they can be for those they serve. And I just respectfully ask that you, the Alleghany Board of Commissioners, please consider hearing what Partners has to say and offer, as I strongly feel that our needs in Alleghany County align better with what they have to offer us. Thank you.
Yeah, we do have individual meetings with VIA and with Partners scheduled later on this month. So, and there'll be other meetings of this type as well. So again, we appreciate everybody's time today. You know, it's a difficult decision. You know, we need more providers. It's sort of a chicken and an egg, you know. Is it, are there not enough providers because, you know, is it a supply-demand issue? I mean, there's a lot of factors involved with where we are and where we're going to be able to go. But we appreciate everybody's time. Anything final from my esteemed board up here?
Thank you for what you do. God bless you.
Okay, thank you all.